And now we're moving to our next plenary, titled Divergent Roads to Progress, a country-by-country examination of the challenges overcome and the factors that led to success. This session will provide an overview of key issues to consider in order to accelerate progress and will allow us to delve further into these issues by exploring specific experiences shared directly from different countries. Our moderator is Ms. Mary Kinney, a health policy and systems researcher at the University of Western Cape's School of Public Health in South Africa. Mary is not far from me, maybe a few minutes away. Welcome, Mary, and thank you very much for moderating this plenary 2 of our day 1 of our forum. Over to you.
Welcome and thank you for joining. Today I have the pleasure of moderating this important session that will bring to light some examples of how countries have been able to advance maternal and newborn health in the past couple of decades. We know one of the best ways to improve maternal and newborn health is to learn from countries that have overcome big challenges in the past. This session seeks to learn from 4 countries, Bangladesh, Guatemala, Nepal, and Sierra Leone. While recognizing that there's no right way or cookie-cutter approach, we still want to find out from these countries what made them progress so much in the past couple of decades and see what strategies could be adapted in other settings. These 4 country case studies are drawn from 2 ongoing projects, the MNH Exemplar work and the WHO Maternal Health Scoping Review work. Both of the projects are conducting case studies to identify key levers that have led to this progress. However, it's important to note that these projects vary slightly in purpose and therefore their country selection process varied. The Maternal and Newborn Health Exemplar work selected countries based on mortality reduction, whereas the WHO Maternal Health Scoping Review includes case studies across different countries that are at different phases of the obstetric transition, and this is based on the level of mortality. So Sierra Leone is in stage 1 of the obstetric transition, meaning it has very high maternal mortality, yet they've actually made incredible gains in the past couple of decades. The other 3 countries are at stage 3. The session will include a short presentation about the 4 countries to give helpful context for a lively discussion so that the speakers can share some of their successful stories and factors and lessons learned. Since this is ongoing work, there may not be any final answers or straightforward comments, but all of the speakers have been working on these case study research projects and come with vast experience of working in maternal and newborn health in these countries for the past couple of decades. Therefore, we look forward to questions and feedback from those who are listening to the session. Before I present, I would like to introduce our esteemed panel of speakers. These introductions are short to save time for the session, so please go to the conference online web platform to read the full bios of these extraordinary people. Dr. Shams Al-Arifin is the PI for the Bangladesh MNH Exemplar Project. He is the Senior Director of the Maternal and Child Health Division at ICDDRB and a professor at Brock University in Bangladesh. Dr. Sachi Kane has led the WHO Maternal Health Scoping Review case study for the Ministry of Health and Sanitation in Sierra Leone, and he is currently the Acting Chief Medical Officer for Public Health at the Ministry, and is also Director of Reproductive and Child Health, a position he has held for the last 3 years. Dr. Karen Slowing is the Principal Researcher for the WHO Maternal Health Scoping Review case study in Guatemala. She works with PAHO and previously served as the State Secretary for Planning and Programming for the Government of Guatemala. And finally, Dr. Sudha Sharma is the PI for the Nepal MNH Exemplar Study. She is the co-director at CWEC Hospital and Travel Medicine Center and previously served as the Secretary of the Ministry of Health and Population in Nepal. So now I will hand over to Dr. Shams to give the presentation.
Thank you, Mary. The 2 projects that have produced the case studies for these 4 countries have used similar conceptual frameworks for MNH that include a range of interrelated factors. The framework originally was developed to provide a theoretical underpinning of mixed methods case studies to better understand how countries reduced maternal, newborn mortality, and stillbirths in the last few decades. If you look at the slide from right to left, it includes impact factors or outcomes, proximate indicators measured by intervention coverage and equity, and intermediate factors that include both program and service levers, as well as household and individual context. Also on more distal factors, which includes health policy and system levers and other contextual influences. This presentation will give a very broad overview of where the 4 countries that we're dealing with sit in terms of these factors. The intention is not here to present a comprehensive background for each country or to do a country comparison, a cross-country comparison, but rather to provide a brief comparison or to show where what are the differences between the countries, where do they sit as we discuss each country's road to progress. Geographically, all the countries are about the same size, but there is wide variation in urban, rural density, population densities, population sizes, and total fertility rates. As you can see from the numbers on the top, Bangladesh has the largest population by far with almost 170 million people. Guatemala has the highest urban population density at about 51%. Fertility rates are low in Nepal and Bangladesh, whereas Sierra Leone has the highest fertility rates. This first slide, I believe you may have seen in the earlier plenary as part of the video. What we see here is a distribution of all the countries globally in terms of the perinatal mortality rates on the x-axis and the maternal mortality ratios on the y-axis. And we have marked the 4 countries that are being part of this session to get a sense of where they are on the scale, and they do differ quite a bit. Mortality rates have decreased across all the 4 countries. Stillbirth rates have declined more slowly than maternal mortality and newborn mortality, and there are real data quality issues with stillbirths. It's not a surprise that Bangladesh and Nepal, which are exemplar countries, have the highest annual rates of change across all indicators. While Sierra Leone still has high MMR, there has been quite dramatic declines in the past 2 decades in terms of maternal mortality. A bit busy slide here. This slide shows that the coverage indicators across the life course for maternal and newborn health, and the data has been taken from the latest available DHS and now any other equivalent survey. As we can see, there are many interventions required for the continuum of care, MNH continuum of care, and which basically means that we need robust measurement systems to track all these indicators. And we also see quite a bit of variation between the indicators and between the countries. In this slide, we zoom in on a subset of these indicators to see the variation between countries and indicators. And as expected, across all countries, ANC1 is higher than ANC4. However, in Bangladesh, ANC4 is substantially lower than ANC1, whereas in Guatemala, the postnatal care is quite substantially, surprisingly lower than postnatal care for mothers. And these basically highlight that there are variations along this continuum, and I think there is now increasing kind of attention to measuring content of care within each of these intervention package and go beyond just measuring contacts, which is what these bars are showing. In this slide, we will walk you through how these 4 countries have changed in terms of distribution of place and staff at delivery. Starting first, and we're comparing two surveys for each country. Starting with this dark bar that shows the percentage of deliveries that happened at home alone in the absence of a provider. These lighter bars show quite the distribution of home deliveries in the hands of a non-SPA. Even lighter green bars show home deliveries in the hands of an SPA. These bars show the contribution of facility deliveries in the absence of an SPA or where the delivery happened alone. These are facility deliveries with lower level facilities with nurse midwives, lower level facilities with doctors, upper level facilities with nurses or midwives, and upper level facilities with doctors. And as you can see, there's quite a bit of variation between countries, and the changes are quite different. Bangladesh and Sierra Leone have made transitions to facility deliveries at lower levels, whereas Nepal and Guatemala have transitioned to a high proportion of births at higher facilities. This graph also kind of highlights the challenges that we have in measuring, for example, indicators like skilled birth attendance, because they are defined differently in different countries. Also with facility deliveries, not surprisingly, that when we start making distinction between lower and higher level facilities, it becomes a challenge because these are also differently defined in different countries. And as an example, we note that Sierra Leone has had the highest increase in SBA, but most of that increase has been at lower level facilities in the hands of nurses and midwives. Whereas in Bangladesh, the shift has been to births to lower level facilities, but mostly in the hands of doctors. We move on now to look at SPAs and one aspect of SPA of looking at equities. So we are looking at trends in inequities over time. So what we note here that in all four countries, things have been changing over time. Bangladesh and Nepal have not made as much progress as Guatemala and Sierra Leone has. And as you will see in Guatemala and Sierra Leone, they do seem to have improved quite a bit, especially Sierra Leone, where inequities seem to have almost entirely disappeared. We now look at another indicator, C-section rates. Again, looking at distribution of C-section rates by types nationally as well as by facility types. This is an important indicator for MNH. And what we see here is the C-section rates are highest in private health facilities across all four countries. We look in this slide, we look at C-section rates by wealth quintiles. And again, as expected, the poorest have, even in countries like Bangladesh, where C-section rates really have skyrocketed, and the poorest do have fairly high C-section rates. It does illustrate the lack of access for these higher level care among the poorest. But also we see this over medicalization among the wealthiest. If you look at countries like Bangladesh and Guatemala, having in the wealthiest quintile, 60% and 50+% of women delivering in a C-section is really quite almost hitting the roof there. We now move on to looking at some contextual information because they are important in understanding how MNH has changed over the years in these four countries. We first look at health expenditure and by source, and the contribution of out-of-pocket expenditure as well as the contribution of the government expenditures. And what you will see is that out-of-pocket expenditure remains high in all four countries, and the government expenditure is, as a percentage of total expenditure, government expenditure remains low at less than 10% in all four countries. Looking at density of health workers, doctors and nurse midwives, all four countries fail to meet the WHO kind of the recommendation of 44.5 health workers per 10,000 population. But we see a difference between the countries, with Bangladesh having more doctors proportionately than other countries, who tend to have more nurses and midwives. And basically the message is there's not enough human resources in these countries. Literacy rates education is another important social variable that is of importance in understanding changes we have seen in MNH outcomes. It is an important social determinants, and as we see here, almost all countries have increased quite considerably in terms of female literacy, but they do vary. Some countries have done better than others. Looking now at wealth again, that's again an important indicator for the country and also how it affects MNH. We also see again that all countries have gained, but there are variations between these countries. And we note here that these non-health issues are extremely important and they have important impact on health well-being of women and children. And each of these 4 countries have faced unique challenges the last 2 decades. With that, I will close the presentation. I would like to acknowledge that the presentation was done in partnership with many partners and was a collaborative effort. And I'll hand over to Mary for continuing with the discussion.
We will start with Sierra Leone. Dr. Sati, in the presentation, we saw that Sierra Leone has made remarkable progress and has even achieved a real equity gap reduction. In fact, the greatest out of any of the 4 countries. So could you please share what happened to get you that reduced equity gap and increased coverage?
Thank you very much, Mary. I want to thank you for the opportunity. Of course, several factors are responsible for that. And one of it is actually the political will, which has been very, very strong ever since after the rebel war and Ebola. And our political structures, our legislature, and our policy environments are supporting that, and donors are aligned with all those policies, which is actually helping us. The second one is actually our extensive primary healthcare infrastructure that is way down to community levels with well-defined structures and tax shifting, which actually enables us to do a lot of things, and also the referral systems, which links all these people together. These two put together really enables us to have improved access to emergency health services. Free healthcare is another one that actually takes cost away from as a barrier to access to these targeted groups. And it has actually shown that we are accessing more and more people as we go. You know, nutrition and education is at the middle of our high maternal neonatal mortality. And because of that, the government have actually done a free quality education program with a lot of nutrition school feeding programs. And there's a multi-sectorial plan and collaboration to really try to combat the nutrition issues. For quality, as the major thing, which is really underpinning our high indicators still, impact indicators, we have actually begged to join the Global Quality Equity Care Network for RMNCH in 2017, which we are now part of it, and we are actually tracking how well we are doing in qualities with quality improvement and other things. Thank you very much.
Thank you. Clearly, you have taken great efforts to reduce the barriers to access and increase utilization of services. Dr. Shams, we heard earlier about the importance of investing in actions beyond the health system. And in the presentation, you showed the incredible progress Bangladesh has made for MNH in the past decade. And not just in MNH specifically, but also in the social determinants such as female literacy and young women. Can you share what are some of the key levers that enabled this progress, including those outside of the health sector?
Thank you, Mary. There is really no doubt that Bangladesh's achievements on MNH, particularly the maternal mortality, has been largely driven by the improved access and use of health facilities. The country has invested heavily in public sector facilities, particularly secondary and tertiary level facilities. There has also been an explosion of private facilities, given the huge, largely unregulated space provided. Having said that, the contribution of social determinants has been enormous. Literacy rates among young women, especially among 15 to 24-year-olds, is now near universal. The rate was only 60% 2 decades ago, and only about a quarter in the early 80s. In fact, if you look at the teenagers now, rates of schooling are higher among girls than among boys. This has played out in terms of better care during pregnancy, but also in terms of better care seeking when complications arise. Even though a large proportion of deliveries still happen at home, and which is changing though, there has been a substantial increase in care seeking for maternal newborn complications. And because of the investment in health services, these facilities are not very far away. There are problems with the facilities, but that is for another day to discuss. The investments in social development is also reflected in reductions in fertility levels, which has declined to near replacements. This has not only resulted in significantly lower births, but which by itself would reduce the number of maternal deaths. When you have fewer births, you will have fewer deaths. But it should not directly affect the mortality ratio. But that has also changed because of two additional ways. One was the lower fertility also means fewer higher risk pregnancies and births. And two, every pregnancy birth are now more valuable to the families. That means better care, made even more effective by having more educated families. Finally, the household income has increased in Bangladesh, particularly sharply in the recent years, and poverty rates have fallen. And a greater proportion of families can seek and pay for care in the private sector, which has expanded at the same time. I should add that, this investment in education that the country has made that goes back to several decades was never designed to be with the intent of impacting on health. So it was done primarily to improve the social well-being of the population. But I think people realize that there is an effect of better schooling on health, and there is much more interest in multi-sectorial interventions, which are challenging because we have seen historically that there's different ministries don't like working with each other. But so let's see what happens with that. But there is quite a bit of interest there, and maybe some of the new funding mechanisms will make it make a difference there.
Great, thank you for highlighting all of those important points, and particularly the multi-sectoral action needed moving forward. Dr. Sharma, we just heard from Sierra Leone about their free healthcare initiative and efforts to expand service delivery. We know that Nepal has made impressive gains and is an exemplar country, but you took a different approach. Can you please share some key factors that led to your success, including key policies and programs?
Thank you very much for this opportunity. In fact, I would like to highlight two factors in this demand side and two on the supply side. On the demand side, in Nepal, we have 50,000 strong female community health volunteers who promote care seeking and also supply family planning commodities and oral rehydration solution to ensure women seek care and newborns they survive newborn and children. So that's one aspect. The second is, like Sierra Leone, even in Nepal, maternity care has been free since 2008. But even before that, since 2005, the government had given incentive to encourage women to come to health facilities, by providing transport support cost. Nepal is a mountainous country with lots of challenges in transport, so that was a great help. And subsequently, even care for newborn has been added as a free care. So that helps. These are the two demand side incentives. And on the supply side, like Sierra Leone, we do have a strong public health network, which has increased successively over the years. For example, in 1995, only 14 of the 77 districts had comprehensive emergency obstetric newborn care. Now, over 219 facilities in 72 of the 77 districts of Nepal provide a C-section facility and the range of comprehensive obstetric care. And that has been facilitated by the development of human resources, a large number of doctors, nurses, skilled birth attendant to whom we have allowed a certain basic emergency functions to be performed even by the nurses and midwives, and also by promoting the general practitioners, medical practitioners to do cesarean sections. So all of these work on the demand and supply side, I think they have contributed to really improve the situation of maternal health in Nepal and to bring down maternal and newborn mortality to a great extent. And like Sierra Leone, our political commitment has also been a very, very key factor in all of this. Thank you.
Thank you, Dr. Sharma. And that last point on strengthening the health workforce is really critical. And so we're going to shift to Guatemala. Dr. Slowing, maternal and newborn health implementation was strengthened by improving the numbers and skills of providers in Guatemala as well. Yet we saw in the presentation that doctors remain the major provider for facility deliveries. So could you talk a bit about the role of midwives and what challenges you've had to overcome?
Yes, indeed. Guatemala does not have Western-type midwives as part of the health workforce. And that is the reason why expansion of services had to rely on medical doctors and nurses. However, there is a long history of traditional indigenous midwives, mainly from Mayan origin, who are still the backbone for maternal and neonatal health care in the rural communities. In spite of the Ministry of Health having regular training for them, they are not recognized as skilled personnel. And that explains why, in our case, we have so many doctors still in charge of childbirth. Nevertheless, women and families trust traditional midwives more and go first to them and then to the health services. And that is the reason why about a decade ago, the Ministry of Health took important steps forward to make the health services more cultural pertinent, allowing, for example, traditional midwives to stay with the patients in the medical facilities of the Ministry of Health until delivery, and also providing the option, for example, of vertical birth. Likewise, there have been efforts to sensitize the health personnel and train them on how to work in multicultural settings and how to prevent racism and discrimination against traditional midwives. This has been a strong effort and has been backed not only by training, but also by policy making. This is a very important step forward in our case. And even though we recognize that there is still a very long way to go in this matter, the initial steps have been taken and have shown some improvements.
Thank you for sharing about the investments in the health workforce, and particularly noting that investments also include engaging traditional healthcare providers and also training health workers to provide respectful care for all. So in the second round of questions, we're going to focus on factors that have been influenced through the policy process, from the development of the policy to the implementation of it. In terms of the policy process, Bangladesh invested repeatedly and heavily in large national maternal health surveys. Can you talk about what their actual contribution was to the policy and process, and how do you see this evolving moving forward?
Between 2001 and 2016, 3 large national maternal health and mortality surveys were conducted by the Ministry of Health. The first one had a sample size of 100,000 households, the second 175,000 households, the third over 300,000 households. As I mentioned just now, these were conducted and owned by the Ministry of Health. In fact, it was done by an institute of the ministry. And there was quite a bit of support from several development partners, particularly USAID. The evidence generated by these surveys, particularly the direct mortality estimates, and the model estimates that we receive from the UN system, did trigger a considerable and ongoing debate within the country about policies and program choices. This was also the period when the National Maternal Health Strategy, the National Neonatal Health Strategy were all being developed, and also a comprehensive set of newborn interventions were being rolled out. This was also the period when the country started the rollout of properly trained midwives for the very first time. I'm not saying these surveys contributed to that, but I think the debate helped. The debate that was generated by these surveys helped. There are significant advantages of having your own directly estimated MNH indicators. We had it from the 3 surveys, but also from the DHS and MIX, which were also happening at the same time. Why? Because you own the data, you feel that they are speaking to you directly, and it's very difficult to run away from such data, which are your own. And as I've said, these form the basis of continuing dialogue within the country. Often these dialogue was opportunistic, but still effective. Having said all that, we realize it's going to be difficult to pay for future maternal health service because they will need to be even larger given the declining mortality rates. So now there is increasing attention to routine data, which needs to be better quality, more comprehensive, and there is also quite a bit of investment that is going into civil registration.
No, thank you so much for demonstrating the importance of data ownership and data use for informing the policy process. It's definitely a critical lever. Now in Guatemala, Dr. Schmeling, you've also had strong policies in place. What role have the different actors played in supporting the Ministry of Health in the policy process to achieve your significant mortality reductions?
Well, national and local level partnerships have been critical to achieving and improving coverage and also to sustain long-term commitment and investments. I want to highlight some of the critical stakeholders that in our case have managed to make breakthroughs in this process. First of all, our Congress, the National Congress, particularly Congress women that have pushed very strongly to enact critical laws in our country, particularly contraception law that allows the Ministry of Health to provide contraceptives to the women, and also the Safe Motherhood Law. We also have a very strong organized civil society that for the last 10 years have set up a reproductive health observatory, it is called, and they do a continuous monitoring at the local and the national level on what is happening with reproductive health interventions and how maternal mortality rates are behaving. And this, they give feedback to the Ministry of Health in these matters. Also, we have been, by law, have to establish a commission, a multi-sectorial commission for maternal mortality reduction. And this is a body where all stakeholders sit together on a regular basis and carry out joint planning. There you can find, for example, academia, the College of Obstetricians and Medical Doctors, civil society, international donors, and all of them sit together with the Ministry of Health and do the 5-year plan process. So we are nowadays in our 5th 5-year plan process. At the local level, we have the traditional midwives and community leaders, which are critical to make this connection in the rural areas. And finally, the donor community, who has aligned and support continuously throughout the last 20 years this process. This has been critical to our success.
Thank you for taking us through the various actors that have been major role players in the process. Dr. Sachi, you mentioned also the importance of the role of donors and development partners, and you might want to weigh in on that comment. But first, it would be also good to hear how Sierra Leone has demonstrated incredible resilience to shock. Civil wars and epidemics, what's led to this resilience and what policies have been put in place to prepare for the next possible shock?
Thank you. I've already told you about the extensive primary healthcare infrastructure. This infrastructure was used greatly, especially like during the war, to give essential services to even people in those disturbed or zones where they are highly affected. For example, during the war, we used even the rebels themselves through mobile or fixed outreach services to really give them services. After Ebola, we learned a lot. We actually saw how the role the community plays in ending outbreaks, disasters, wherein we have, for example, the community healthcare workers at that local level, and we have the maternal child health assistants in that local community who have the function of actually maternal neonatal child health issues, and at the same time, they have the surveillance functions to perform. But at the same time, we also used what we call the neighborhood watch within the communities, where everybody is doing a lot of things, and we call it the event-based monitoring. Every event within communities are being packeted through the CHWs, and that's how it's linked towards the community. So we are using that greatly even during this outbreak. And these people, no matter what happens, they are always in the communities. They don't come out. So even when people run away from there, we have a mass of people who can give promotional and preventive services. The other thing is our digitalization of the surveillance system. We will now have the EIDSR system, where we've integrated our maternal death surveillance and response system in it, and our routine health information system. So this actually gives us a near real-time monitoring of most of these events, and then even service uptake. And what we've now done, anytime we have an outbreak or whatsoever, we have a special pillar, which we call essential service delivery pillar, apart from you call surveillance and other things, who actually look at service delivery to see that at least essential services are being maintained as we go. We also have the emergency operation centers in all the districts and even at national level, which actually operates and goes with things as they go. So we have these structures as we go, and that is what is really happening. The challenges are, I know maybe similar somewhere, but our major challenge is health systems issues. You look at the human resources, even the infrastructure, PHU infrastructure I'm talking about, as it relates to energy, it relates to wash, it relates to supply chain, you know, and because of some of these things, you realize that even though we make a lot of gains in accesses, but the quality is still the same. Yeah. So like we've done a lot of digitalization, we are getting the information, but then we've realized that we are like for ANC, we are doing much of the visits instead of the contacts because of what we really need to be at the facilities. Thank you.
Thank you, Dr. Sarti. Really highlighting some of the key factors that you've done, particularly at the community level and the primary healthcare level. Dr. Sharma, we know that in Nepal, you've had very strong policies for maternal and newborn health, which have been successfully implemented. What do you think lies behind these successes?
Political commitment, I've already mentioned. So on top of that, I think the flexibility of our approaches. You know, we do small scale studies and see whether the policy has been effective or not, and then quickly make adjustments and then scale up, you know. In that sense, the adaptability and the flexibility and rallying in by the professional societies behind the policies and then helping the government to implement, I think that has played a critical role. And private sector also has a big role to play in making these policies successful. The infrastructure in terms of the public health facilities have really grown, but that has been possible because the private sector has also contributed by adopting a couple of districts in providing human resource. You know, when I was graduating just about 50 years ago, there was no medical college in Nepal. Now there are over 20 medical schools, and many of them are private, but they also adopt certain remote districts and then take medical camps or take human resources and make services available. And the referral network of utilizing these facilities has been excellent. And about 10% of these private beds are supposed to be providing free care to everybody. And in the free AMA program, we call it AMA program, the free incentive care program, which I mentioned earlier, even the private sector is participating in that. And, you know, as a result, as you saw, our C-section rates are going good, but not over-medicalized because government is really closely monitoring how things are done. In fact, we do studies to using the Robson's criteria that has been set up by WHO to keep the number under check. And the Nepal Society of Obstetrician Gynecologists working with the government has really played a key role in this. So altogether, I guess it's the flexibility, the government partnership with the, you know, our external development partners and the private sector, all of that, and a strong health sector like in Sierra Leone, you know, the sector-wide approach. I think all of these have been very, very key. Thank you.
Thank you. That was such a rich response with so much depth in there. And it just also reminds us that continuous engagement and communication is really key to that flexibility and engagement of so many different partners. So now we're going to shift to the audience for their questions and contributions. Greetings from Cape Town. That's where I am based. It's lovely to have you all here, and we look forward to hosting you in Cape Town when we have the face-to-face Align MNH conference. We're going to have our questions and answers now, and are so grateful for all of you who have added questions already. We have a robust list. Keep them coming. We'll try to address as many as we can in the 15 minutes that we have. And then if not, then we'll try to continue that conversation on social media and through the Align MNH platform. So I will start with Dr. Shams, you had quite a few questions actually about how Bangladesh managed to reduce mortality despite low institutional deliveries, the impact of the private sector on antenatal care and on C-sections. And I wanted to know if you could explain some of this a bit further, because you didn't have a lot of time in the discussion, and perhaps also the consequence of the active private sector. Thanks.
Not an easy question to answer. I don't think we really know. We can, but there's some evidence, and the rest is another country and what is happening here. I think based on what we have seen so far and the little evidence that we have, even though home delivery is still quite common and it's just dropping below 50% in the last few surveys. Access to facilities when complications appear is not very difficult. We are a small country geographically. I think it's geography that helps us quite a bit. So if you just look at the population density of this country, no other large country of 10 million more are even close to us. The closest is 2.5 times less dense than us. So I think distance are less relevant for Bangladesh than anywhere else. So having invested in facilities and allowing the private sector to open up facilities everywhere allows people to go out if they have complications. Even if they're delivering at home, if the baby is at home, if there is complications, you are able to go out and there has been huge investments in transportation, road transportations, internal roads within the villages, between villages have really improved. So I think that's probably has made in early years, and if you look at the last 20 years, much of the improvements we saw in the first part of the last 2 decades is because of that. Over. And so you had a second question, Mary, which was I forgot, which was the private sector something.
It was C-sections.
Okay, sure. Oh, C-sections. Yeah.
Go ahead.
No, actually, it is painful. It really is an effect of money talking and letting loose the private sector. It is. I think the financial incentive is probably what is driving this very high rates of C-section in this country, even among the poor. And I think there's no easy solution to this. I think there was a question in the chat box about some sort of balance. Yes, I think we do need to move towards monitoring will help, but we need to move towards a structure, a service delivery structure that is not incentivizing C-sections. Right now, the existing structure incentivizes that. Over.
Thanks, Dr. Shams. Dr. Sudha, I know you also wanted to come in on the private sector, and there was a comment from Blani who mentioned that in Burkina Faso, the Ministry of Health has not been able to make the private sector support the free MNH care policy, but you were able to do that in Nepal. And we're wondering if you can comment on that for us, please.
It's always a challenge to bring private sector on board, but in Nepal, we have given them not just the maternity care program, but other, like for example, I highlighted about them adopting certain districts and also involving them in the planning process itself. So that has been key. And, many of these private medical colleges and private hospitals, they want to attract patients, they want to popularize themselves. So this free AMA program is like an entry point. If they come through the free program once, many people, their families, their relatives, their community know about the facilities, which indirectly attracts more clients to come to their facility in due course of time. So maybe that's one of the reasons, but it has been very successful, I think, in Nepal, And although the rates are very low in the government sector with the AMA program, whereas those who are not enrolled in AMA program, they charge quite high rates. But even then, it has been quite attractive because I guess the numbers matter,
Great. Thank you very much. Dr. Sarti, let's shift to you. There were two questions that we wanted to address. One was specifically to you from Samuel. How can we improve the maternal and newborn outcomes at the lower level facilities, especially in Sierra Leone? Or do we push for more deliveries at higher level facilities and allow the lower level facilities to concentrate on antenatal care and postnatal care?
Yeah, thank you very much, Mary. As if Samuel is just within our system. As we move forward, we are now moving towards the hubs and spokes model in this country, wherein we want more preventive and promotive services to be done at the very lower end as we prepare the hubs that are centrally or strategically located, staffed enough, and then with equipments and the like to be doing the deliveries. Yeah, of course, because of our road network issues, we may also see challenges with the referrals, but we have really strengthened that one, and there's an emergency services now that is really bridging that gap. So that is the direction, of course, and that is the call, and we've started. I told you the last time that we are really moving towards the quality issues, and that is one of our strategies, where we'll have the spokes to do what they can do in preventive and promotive, and then refer in time. So if we do it even very well, we may not need a lot of ambulance services, and that will cut down on resources. And we are using the UHC model to really have a comprehensive package for service delivery at even the hubs. Thank you.
Thank you, Dr. Sarti. And that also addresses the question from Loveday on referral systems. And I just want to also ask Dr. Slowing, there was a question from Allison on what intentional efforts were done to reach the most vulnerable, and what did you learn from those efforts, and what will you do moving forward? And this is something you also mentioned in your talking points earlier. I thought you could elaborate a bit further on what you've done and what you're hoping to do moving forward. Thanks, Dr. Slowing.
Thank you. Greetings from Guatemala to everyone. Well, I think that one of the most that we have done well during the last 20 years was to expand institutional services throughout the rural areas. We had in concrete two moments or two waves of expansion of services, basically primary and secondary level services. The first one was at the beginning of the century, and this was done by means of the support of NGOs and other non-profit institutions in particularly, who were organized by the Ministry of Health to deliver a basic package of services to rural populations that were formerly not reached by the Ministry of Health. And the second wave at the mid of the century, concretely between 2008 and 2011, where we had a new expansion of secondary level of care in rural areas. And there the health workforce was mainly from medical doctors and nurses. We improved the ability to provide secondary care and surgery and delivery in hospital-based facilities and health centers that were improved, so that the mother and child did not have to move very far away from their communities to have that access. I believe those two things were critical, and the third one was a struggle mainly pushed by the traditional indigenous midwives in Guatemala to have a increasing more prominent role in making cultural pertinent all the health services. And what this has meant for them a big struggle, because sometimes health services are not very open to that kind of situations. But in fact, they have managed to become more involved in the health system, allowing, for example, for women to be accompanied by them until the time of delivery, to facilitate vertical delivery and so on. The other important thing that the country has to do differently is that our main concern right now is that we need to prevent stagnation of our decline in maternal mortality reduction. And for doing that, we definitely need a third wave of expansion of rural services. We need to have a more strong involvement of traditional midwives with better skills to provide services. And we also have to focus in those rural areas in which the programs have not yet been able to go in sufficiently. And that will improve also equity, which was one of the other questions that was raised. Funding for that is critical, and our Safe Motherhood law allows for some permanent basic funding for these programs to be constant, but we definitely need to improve the range of that funding, public funding in particular, so that we can reach the most vulnerable. Thank you.
Thank you, Dr. Slowing. There are still so many questions and they're still coming in. We haven't managed to get to questions on quality and budgets, which are really important. So I do think we'll have to capture all of these and come back to you via the platform. For now, we're going to have to wrap up, unfortunately, but I'd like to give each of our esteemed panelists just 1 minute each of their concluding thoughts on their road to progress. And I'll go alphabetically by country. So we'll start with Bangladesh. Dr. Shams.
What needs to happen is we really need to invest in better routine data systems. And we have to let the data speak to us, even if we don't like it. And often we don't like it. And I've seen plenty of examples of that. So I think that's is going to help us a lot in the future.
Thank you, Dr. Shams. Great. For Guatemala, Dr. Slowing.
Thank you. If our country is going to move forward, we need to address at least 3 issues. First of all, prioritize inequality and reduce gaps between Indigenous and non-Indigenous women, and also between the urban and rural. Although we have made a big leap forward, we still have challenges in that regard. And in that context, I believe that moving from national targets to subnational and district level targets is very important. Secondly, we need to revitalize and strengthen the information systems to provide us with timely and reliable data. And thirdly, we have to expand, develop, and renovate our primary health care system so that we can reach the women wherever they are, instead of trying to bring them to the services. Thank you very much.
Thank you. For Nepal, Dr. Sharma.
Thank you, Mary. For Nepal, I think we've done a lot in increasing access and coverage, but we still need to do a lot on quality and reducing inequities. So for that, for quality, the government is doing a lot of things with the support of many partners, which include developing mentors at the local level. And I think this program needs to continue to be strengthened. For the equity, now Nepal has gone into a federal system, and there's municipalities and the federal governments, the provincial governments, they have a big role to play. Their capacity needs to be strengthened, and I think jointly we are giving more attention to that issue. And Nepal's mountainous terrain continues to pose a problem. So we are improving the referral system, transport mechanism, so that now we have a president's program whereby helicopter lifts are also provided to women. But, given the challenges with airfield and with the weather, things are pretty difficult. But despite that, we are doing good. We need all your support. And I think the discussion that have come up here will also help us guide and learn between countries. So I would like to thank everyone for this opportunity. Thank you.
Thank you. Dr. Sarti from Sierra Leone, please, last words.
Thank you, Mary. As we said, quality is actually where we are going to stress going forward. And we are on the right track. And we'll continue to really see how we can provide quality, especially at the lower level. And we'll use the UHC roadmap as a vehicle towards 2023 to see how we can improve or even provide quality emergency obstetric services at that lower level. That is equipping the lower level with staff, with everything that will be needed to see that people really do suffer too much for it. Of course, the other thing is we have to invest more in our health systems going forward. And with all partners together, we know we can handle and go ahead. Thank you.
Wonderful. A big thank you to each of our speakers here. Today, we heard a wide variety of factors that have led to progress for maternal and newborn health in these 4 countries. I'll highlight 5. Political commitment and laws that protect women's rights and safe motherhood. Prioritizing access, respectful care, and quality by ensuring a functional and integrated health system across all levels, primary all the way through tertiary level. People investing in health workers at the front lines. Partnerships through continuous engagement of all the various actors, including women, parents, and communities to ensure accountability. And finally, the power of local evidence and data in informing policy process. So since these case studies are still underway, we look forward to learning more from them as they continue to unpack the complex web of factors that influenced progress. Understanding health policy and systems drivers really requires a lot of robust research that considers both the tangible factors as well as examines the less observable elements that shape human behavior in health systems. So we look forward to those final case study reports, and we thank everyone who was involved in the session. It was a really dynamic partnership, and we need more of that in order to accelerate progress for maternal newborn health, and using this platform of Align MNH will be such of a device to do that. So thank you very much, and now we hand back to Dr. T.
Thank you, Mary and colleagues, for such insightful discussions. Each country showed impressive achievements, but took slightly different paths to get there. And we saw the need to move beyond merely measuring contact and focus more on quality, and the importance, of course, of equity, with a look at skilled birth attendants across wealth quintiles, and the complex issue of cesarean section rates, both overuse and underuse. And these examples stress the importance of contextual factors, but also key to success. Prioritizing MNH with strong policies and plans in place, aligning donors and partners, rallying professional associations, and coordinating across sectors. Additionally, we heard the importance of investing in the health workforce, including responsibilities of task shifting and task sharing, and the strong need to focus on equity and quality. We will now transition to our concurrent technical sessions. Please visit the Agenda tab and select the concurrent session of your choice. You can select from 3 sessions, one focused on antenatal corticosteroids for improving preterm neonatal survival, another on the National Forums on improving quality of care for MNCH, also a session on improving the experience of care and mistreatment of women during childbirth and of newborns. It will be a tough choice, no doubt about that, but rest assured that a full recording of each session will be available on demand post-forum. After the concurrent sessions, I look forward to having you join us back in the main virtual plenary room as we close out day 1. As you transition into the concurrent sessions, please enjoy a selection of our videos from our partners at PMNCH and the White Ribbon Alliance produced that will begin rolling 2 minutes before the advertised start of the session. All of these videos highlighting community voices will be available post-forum viewing via links from our partners on the Align MNH website.